Hello, everyone. Welcome to today's session on diabetes and kidney disease. My name is Paula Neves, and I'm the lead for the Center for Living Organ Donation. Thank you very much for joining us. As usual, we have terrific speakers for you today and an hour to address your questions. So I would like to introduce our speakers. Dr. Sunita Singh, who's Medical Director of the Living Kidney Donation Program at the Ajmera Transplant Center, and also has a research interest in diabetes in transplant patients. And we are also joined today by Andrea Norgate, who is a coordinator for the kidney, pancreas, and islet transplant a coordinator in the kidney, pancreas, islet transplant program. So, Andrea will also be sharing her journey as a living kidney donor and also her family's experience with diabetes. As usual, we welcome your questions. Please visit us on slido.com. The event code is kidney. So slido.com and event code kidney. And I'd like to now turn it over to Dr. Singh to take us through the first part of today's presentation. Dr. Singh?
Thanks, Paula, and thank you everyone for joining us today. It's great to be with you. As indicated, today's topic of a discussion is diabetes and kidney disease. So next slide. The objectives for today's talk is really to discuss the impacts of diabetes on health. We're also going to be discussing the effects of diabetes on the kidney, and also to discuss transplantation as a treatment option for people who have kidney disease as a result of their diabetes. Now, keep in mind that diabetes is a very broad topic, and this is a brief seminar, so we will not be able to cover every topic related to diabetes, but I certainly will try to give you the highlights or the main take-home points, and we're happy to take questions afterwards if there's something we haven't had a chance to address. Next slide. So first, what is the impact of diabetes on health? So this is an important topic. Next slide. It's important to know that diabetes worldwide is very common. Over 400 million people with diabetes. There are over 400 million people with diabetes worldwide, and 50% of those will have some kidney involvement or kidney damage as a result of their diabetes in their lifetime. Next slide. In Canada, the problem is also a major one. We know that 29% of Canadians live with diabetes or pre-diabetes, which is that kind of stage of some abnormalities in blood sugar, but not full diagnosis of diabetes. And 10% of Canadians live with diagnosed diabetes. And I say diagnosed diabetes because there are likely many individuals who do have diabetes but are unaware of it because they haven't been tested or screened for it. 1 in 10 women who give birth also experience diabetes while pregnant, which can have implications for mom and baby. And diabetes has an important impact on overall health and well-being. We know that diabetes can reduce lifespan by 5 to 15 years, and that the mortality among Canadians who have diabetes is twice as high as those who are living without diabetes. And also diabetes is the leading cause of kidney disease worldwide, but in Canada as well. So an important issue that we tackle with in Canada and beyond. Next slide. This is a slide that highlights some of the complications of diabetes, and it's really a slide that doesn't capture every single one by any means, but I'm highlighting here the major complications that diabetes can have on the body. And you can almost be assured that diabetes can affect almost every health system. You can see here that diabetes affects the brain, often in the form of cerebrovascular disease, or also strokes or mini strokes. Can cause eye damage, causing problems with vision, decreased vision or blindness. Can cause kidney damage, heart disease, neuropathy, which is a problem with nerves, as well as diabetic foot issues. So for example, causing amputations or even ulcers of the feet. So diabetes can affect every organ system, and is one of the reasons that it causes so many health issues. Next slide. You can see here on this slide that diabetes is also a major contributor to a lot of the health issues that we see commonly in hospitals. So diabetes contributes to about 30% of strokes. Diabetes is the leading cause of blindness, is responsible for about 40% of heart attacks, causes about 50% of, is the cause about 50% of kidney failure requiring dialysis, and really responsible for the vast majority of non-traumatic leg and foot amputations. Next slide. It's important to also recognize that there are several types of diabetes. So you may have seen already in your internet searches or through conversation various types of diabetes, including type 1, type 2, and gestational diabetes. So type 1 diabetes really results from a lack of insulin production due to the body attacking a certain cell in the body in the pancreas, which is the organ that produces insulin. And insulin is a really important hormone that tells the body to utilize blood sugar for cellular functions. So lack of insulin is the major problem in type 1 diabetes. Type 2 diabetes is not so much an issue of insulin production, but rather insulin resistance, meaning that there's insulin circulating in the body. The hormone is present, but the body is resistant to those actions. And the pancreas is unable to churn out really enough insulin to overcome that resistance. And gestational diabetes often happens because the hormones that are produced by the placenta during pregnancy can also make the cells more resistant to insulin. Next slide. On this table, you can see some of the differences between type 1 diabetes and type 2 diabetes. So you'll see just right from the beginning that type 2 diabetes is by far the most common type. About 90% of people who have diabetes have type 2 diabetes. Type 1 diabetes affects a smaller proportion of people, about 5 to 10% out of all of those who have diabetes. So you can see again in the first row that the problem with insulin is very different in both groups. So in type 1 diabetes, there is no or very little insulin production because of the cell in the pancreas no longer makes it. And in type 2 diabetes, it's too little or too ineffective levels of insulin. The age of diagnosis differs. Now, the diagnosis usually for type 1 diabetes can range between 0 to 40, but is really affecting typically young children or teenagers. So the typical age of onset is often quite younger than those with type 2 diabetes. Usually people who experience type 2 diabetes are older, age 40 plus, although there's certainly an increasing number of children and teens who are experiencing type 2 diabetes. The treatment for both types of diabetes we'll be touching upon later, but in more detail. But of course, the cornerstone of diabetes treatment is healthy eating, physical activity, being able to monitor and treat blood sugar elevations. What you can see here is one of the differences is because type 1 diabetes is really related to none or very little insulin production by the body because of the failure of the attack on the beta cell in the pancreas. Insulin injections or insulin delivery through various mechanisms through injections or a pump are required and essential. Whereas in type 2 diabetes, there's other ways to potentially control blood sugars that do not necessarily involve insulin, but insulin may be needed in these cases. So just some differences between the two types of groups here. Next slide. So what you can see on this slide is really the scenario for a healthy individual, someone with type 1 diabetes and someone with type 2 diabetes. And you can see in the healthy individual, insulin is produced, it binds to the cell and allows blood sugar to enter from the bloodstream into the cell. In type 1 diabetes, there's no production of insulin, so as a result, there's nothing to really signal the cell to uptake that glucose, so there's elevations of blood sugar in the bloodstream. And in type 2 diabetes, although insulin is produced, you can see that the cells just don't respond to the insulin that well, and as a result, the same result is that there's elevated blood sugar in both individuals with type 1 and type 2 diabetes. Next slide. We know that especially for type 2 diabetes, diabetes can present without any obvious signs or symptoms. This is very unusual. In type 1 diabetes, usually symptoms will occur in type 1 diabetes, but numerous people with type 2 diabetes have it but do not know it yet. They may not have any symptoms specifically to it to indicate that there's diabetes. Sometimes it's even diagnosed on a screening test. But some risk factors to consider, and this is not an exhaustive list, but some risk factors for type 2 diabetes in particular is an older age of 40 years or more. A family history is a really important component. So for example, a parent or a sibling with diabetes is an important risk factor. certain ethnic people of ethnic background have a higher predisposition to getting diabetes. So, for example, those of African descent, Asian descent, South Asian descent, Hispanic, or Indigenous groups. People with an elevated body mass index or who may be overweight are also at higher risk of getting type 2 diabetes. Of course, the presence of prediabetes, so that precursor or early stage towards diabetes, can also put one at risk. Having a history of having gestational diabetes, so the diabetes during pregnancy, can put you at risk at having diabetes later in life. And a condition such as called polycystic ovarian syndrome can also create a situation of insulin resistance, so also another risk factor. Next slide. In order to make a diagnosis of diabetes, there's various ways that this can be done, and this can be done often by a family physician. So various different types of testing are possible. Sometimes it will be a fasting test where blood sugar will be measured first thing in the morning after fasting for at least 8 hours. Or it can be a test that looks at blood sugar control over the past several months and kind of gives a summary measure of how high blood sugar has been over the past few months. And if it's above a certain threshold, it can be indicative that the diabetes is present. Or something called a glucose tolerance test, which is a test where a blood sugar level is measured after ingestion of a sugar load. And it's really testing the body's response to that sugar load. And of course, elevated levels in all of these scenarios can indicate diabetes. Next slide. We know that once diabetes occurs or is diagnosed, an important aspect to consider is all of the potential consequences and organs that it can involve. And the importance of early diagnosis is to try to slow or stop the development of these type of complications. So it's really important for diabetes to be diagnosed early. That is an opportunity for the greatest impact for prevention. I'm focusing today's presentation on the kidney. Of course, there's lots of other kind of organs that can be affected, but I'm going to focus today's talk on the kidney, just given our time limitations. So the next section here is really going to describe what we see in terms of the consequences of diabetes on the kidney. So this slide here just really shows you the anatomy of a kidney. So, you know, we have 2 kidneys in our body, and what we don't often appreciate is that the kidney is made up of these small filtering units called nephrons. And you can see here that it's effectively these kind of balls or tufts of cells called the glomerulus that filter blood and then eventually filter out the toxins which go through these tubes and come out as urine. That's the body's way of getting rid of waste. So in one kidney, there are millions and millions of nephrons, and all of them are essentially responsible for filtering blood and removing toxins. Next slide. So if you zoom in on those kind of filtering units, you can see on this slide that diabetes really affects at the various different types of cells. So almost every cell or aspect of these filtering units in the kidney are affected. So you can see on the left part of your screen what a normal filtering unit, or glomerulus as we call them, looks like, and what a glomerulus which is affected by diabetes looks like. And you can see that there's changes in virtually all of the cells, which eventually cause damage to the filtering units, and which explains why we see what we see in terms of diabetes, which I'll touch upon in a few minutes. Next slide. So diabetic kidney disease, which also used to be called diabetic nephropathy in the past, but diabetic kidney disease is really the term to imply that diabetes has affected the kidney function and really presents as a slow and progressive increase in the albumin in the urine. So this is the typical early presentation that the doctor may indicate that albumin, when measured in the urine, is initially there in low levels and then slowly and progressively increases over time. And so you can see on the table at the bottom of the screen kind of the various stages of nephropathy when it comes to albumin excretion. You can see on the very far left that people start initially in the normal phases with no albumin in the urine, and then they slowly progress to having low levels or small amounts of albumin in the urine. This is called microalbuminuria, so small levels, micro. And then over time, eventually that degree of albumin excretion in the urine goes up to a point that one calls overt nephropathy, where there's large amounts of albumin that's being excreted in the, or that's coming out in the urine. Now, keep in mind that, especially for those with who are diagnosed early, it can take actually many years to go from these phases. So typically it can take, somewhere, these are estimates of course, but sometimes 5 years to get kind of from one stage to the next. So for example, on average 5 years to get from a normal stage to a microalbuminuria stage, and then from that stage another 5 years to get to a nephropathy stage. So this is really a slow and progressive, often presentation. Next slide. Then typically what we would see is a decrease in kidney function. We don't see that right away, but then with time, we usually start to see a decrease in the kidney function. Initially, that rate of loss is actually quite slow. And for those who kind of follow their kidney function in terms of glomerular filtration rate, or GFR, you may see a loss every year, about 1 to 2 milliliters per minute of GFR per year. So these are very small changes over time that kind of are almost similar to that of the general population. But what we see in the late phase of diabetic kidney disease is that decline accelerates to a far kind of much more rapid pace. So usually 5 to 10 milliliter per minute loss of GFR over time in the later phase. And really what you can see on this, on the table at the bottom of your screen, is just how long often it can take for some individuals to start presenting with kind of this more severe manifestations of diabetic kidney disease. You can see early on in the first few years after diagnosis, the kidney function is high or normal, and really we start to see decline in the latter phases of the disease, often many, many years later. And often a kidney failure can also happen sometimes 20-30 years after the diagnosis. So it's really a slow and progressive disease, and really one that we want to try to intervene as early as possible to try to slow or stop the progression of the disease. Next slide. It's important to also remember that some of the things that I'm saying about the presentation of diabetic kidney disease is not universal to all individuals. The rate of progression of disease can vary between individuals. For example, those with type 1 and type 2 diabetes may have very different rates of progression. The duration of diabetes, especially the duration of undiagnosed diabetes, where we really don't know how long diabetes was there before diagnosis, can impact how quickly somebody progresses over time. So if somebody was unaware for 10 years that they had diabetes, especially type 2 diabetes that sometimes may not have symptoms, that can obviously affect the rate of decline subsequently of kidney function. And diabetic kidney disease can also coexist with other kidney diseases. So people with diabetes can have other kidney diseases that can accelerate kidney decline, or other risk factors, for example, high blood pressure or smoking, which are risk factors for kidney decline. Those can also accelerate the decline, as well as age. Now, to make a diagnosis of diabetic kidney disease, one has to see persistent kind of high urinary albumin excretion, which is often measured with a test called an ACR, an albumin to creatinine ratio, which is effectively a test of protein in the urine, and or sustained reduction in kidney function. Typically, the cutoff that we use for that is a cutoff of 60 mils per minute. So that is, those two aspects those two components are important in terms of making the diagnosis of diabetic kidney disease. And the treatment goals when diabetic kidney disease is established is to slow or stop the progression of the kidney disease, and to prevent kidney failure and some associated problems that can happen with diabetes, like heart failure, heart disease, and death. So the goals of treatment here are to intervene early as possible, to try to prevent or slow kidney failure and other associated issues. Next slide. So for the treatment of diabetes, and especially diabetic kidney disease, for all patients, really a lot of the treatments really center around glycemic control, so making sure blood sugar is well controlled. And this is particularly important in the early phases to try to prevent the development of complications or delay the development of complications. Intense glucose control early on is really has been shown to be beneficial in the early stages. Blood pressure control is important important. Cholesterol management, these are all things that can affect kidney disease, so it's important to get those under control. Smoking is a strong risk factor for chronic kidney disease and kidney failure, so often a lot of efforts are spent on smoking cessation, and as well as nutrition and regular exercise, which are all important aspects in terms of managing diabetes and diabetic kidney disease. For most patients, the vast majority of patients will be, placed by their nephrologist or family physician on a medication to try to slow or stop the progression of kidney disease. There are various groups of medications out there. Initially, most physicians would use something called RAS blockade, which often referred to as RAS inhibition, ACE or ARB inhibition, for example. And these are medications that work in decreasing the amount of kind of elevations of pressure inside of the kidney to try to decrease the damage. Most recently, which has been really exciting in terms of diabetes advancements, have been the development of these drugs called SGLT2 inhibitors, which are drugs that are used to lower blood sugar in people with diabetes, but also have been shown to significantly impact or lower the risk of death, cardiovascular disease, heart failure, and progression to kidney disease. So these have really started to change how we treat diabetes and diabetic kidney disease. And of course, in order to achieve glycemic control or blood sugar control, sometimes one drug may not be enough. And so often many patients are on multiple drugs together to try to achieve a blood sugar target. So you may see various other add-on medications used to try to control blood sugar in addition to SGLT2 inhibitors. And of course, this talk is not long enough to really cover all of the novel therapies emerging, but novel therapies are kind of in the pipeline and are likely to emerge in terms of treatment of diabetes. The other one that I did not put on this slide, but I mentioned on a previous slide, is just how important insulin is in the management of patients, in particular with type 1 diabetes. That is really for that group of patients an absolute must. Next slide. So we've discussed how diabetic kidney disease can occur and how many patients are affected by that, and how our goal is to stop or slow the progression to kidney disease. Some individuals will progress to end-stage kidney disease or renal failure, or kidney failure as sometimes referred to. And for those individuals, there are treatment options. And in particular, the goal of this section is to talk about kidney transplant as a therapy for diabetic kidney disease or kidney failure from diabetes. Next slide. So we know that 1 in 10 Canadians have chronic kidney disease. That's 4 million people, and 50,000 Canadians have kidney failure, with diabetes being the most common cause. And when it comes to treatment options, often people will be presented with the options of kidney transplantation or dialysis as potential ways to treat their kidney failure. Next slide. For the vast majority of patients, and this is absolutely true for people with diabetes, kidney transplantation is the best treatment option for kidney failure when you compare it with chronic dialysis. And this was shown very early on. This is a slide from a landmark paper in the 1990s, which really compared people who received a kidney transplant and compared those people to those who remained on dialysis therapy. And what you can see early on is the transplant group, represented by the black line, initially around the time of the surgery had a slightly higher risk of death, but over the long term, the survival probability, or the risk of surviving and being alive with a functioning kidney transplant, is far better with a transplant than with dialysis, which is why we recommend kidney transplantation as the therapy of choice. Not only do patients live longer with a transplant, they live better. So the goal here with transplantation is not just survival, but improved quality of life, freedom from dialysis in particular, and I'll touch upon it, pancreas transplantation later, but freedom of insulin as well for a certain subgroup of patients. Next slide. So we talked about increased life expectancy with a kidney transplant, but also improved quality of life, which really means freedom from dialysis, some dietary freedoms as well, the ability to travel without having to be on chronic dialysis. And for those who wish to become pregnant, pregnancy is often easier to achieve with a transplant than with chronic dialysis therapy. And also, of course, potential return to the workforce. Next slide. In terms of different types of kidney transplants, this is a slide that really shows you that at Toronto General Hospital, about 50% or so of kidney transplants are from a deceased donor, so somebody who has passed away, where the organs are donated for transplantation, and then 50% or so are from living donors. So these are friends, family members, parents, children, colleagues, strangers who choose to donate a kidney to help someone in need. So these are the type of kidneys that are utilized for transplantation. And I really want to highlight that for patients with diabetes, not only is kidney transplantation the therapy of choice, but of course, living donation, deceased donation are options that should be considered. But between the two, if one were to choose, living donation is the preferred option if possible. Next slide. Why living kidney donation? So why would one prefer, if possible, to get a transplant from a living kidney donor as opposed to a deceased donor? Well, we know that a living donor kidney, it gives one the best chance for long-term dialysis-free survival. So what does that mean? It means it gives you the best chance of getting off dialysis with a kidney that will be functional over time. So in our program, 50% of individuals have a kidney that works for at least 18 to 20 years from a living donor, compared to 14 to 15 years from a deceased donor. So you can see that the kidney lasts longer if it comes from a living kidney donor. Often, if possible, which is the ideal ways to get something called a preemptive kidney transplant, is to identify a potential person who can donate to you before dialysis is required in order to avoid time on dialysis altogether, or even decrease the time on dialysis. We know that being on dialysis can have consequences to overall health, especially to patients with diabetes. So to try to minimize or avoid that altogether is the ideal scenario, and that can be achieved with living kidney donation. We know that people who receive a transplant from a living kidney donor stay in hospital shorter periods of time and have lower rates of something called delayed graft function, which is when the kidney does not work immediately. And also, importantly, surgery can be scheduled electively for the donor and the recipient at a time that suits both individuals. Next slide. And what you can see here is that over time on this slide, this really represents how the success of our program and the success of kidney transplantation. You can see that very early on, after 6 months or a year after transplant, almost everybody who gets a kidney, either from a deceased donor in blue or a living donor in orange, has a kidney that is working, and they're alive and well. That does decrease over time, as one can expect after transplantation, but at the 10-year mark, you can see that 63% of individuals have a kidney that is working and they are alive and well with a deceased donor, and 73% are alive and well with a functioning kidney from a living donor. So you can see that over time, you really start to see the benefits of living kidney donation. Next slide. One aspect that I think is important to touch upon when we're talking about transplant options for patients with diabetes, as you recall earlier in the presentation, I talked about type 1 diabetes and type 2 diabetes. Although type 1 diabetes constitutes about 10% of the total population with diabetes. Many of them are eligible for a pancreas transplant as well as their kidney transplant if they happen to have kidney failure. And as you can see by this slide, there's a transplanted kidney on the right and a transplanted pancreas into the body on the left side there of that slide of the image. And the goal here is not only to allow someone to become dialysis free, but it's allowing someone with type 1 diabetes to become insulin free, or free of insulin injections, which is a major improvement in quality of life. And I mentioned injections, but there's other ways to have insulin delivered, including via pumps, etc. But I've used injection just as a general term, but acknowledging that there's various different ways of insulin delivery. I also should mention that for a select group of patients with type 2 diabetes, pancreas transplantation can be an option, although there is a much smaller kind of group of eligible individuals for type 2 diabetes. Generally, these are individuals that are generally quite lean, who don't have a high requirement of insulin on a daily basis. And this is carefully assessed by the Pancreas program in terms of eligibility for transplantation, for pancreas transplantation. We have, of course, Andrea Norgate on the line, who is really an expert in this area and who can also address these issues in terms of eligibility for pancreas transplantation. Next slide. This is just a slide to really highlight some of the potential options for patients with type 1 diabetes. What you can see on the slide, if you just follow the arrows to the left, you can just see that people who have reduced kidney function or who are kind of deemed to have kidney failure can be eligible for what we call a simultaneous pancreas kidney transplant. So both the pancreas and the kidney are taken typically from the same donor, from a deceased donor, and are placed into an individual, transplanted into an individual, especially in those who do not have an expected living kidney donor available to them, then 70% of patients will receive typically a simultaneous pancreas kidney transplant, so transplant at the same time. Some individuals will just get a pancreas transplant, and that's really in scenarios where a living kidney donor is available. That person will receive a kidney transplant from a living donor, and then subsequently then get what we call a pancreas after kidney or a pancreas after kidney transplant, which is a second surgery for a pancreas transplantation, which constitutes about 20% of the activity of the program. And then in some individuals where there is no renal failure and no need for a kidney transplant, some individuals will be eligible for just a pancreas transplant alone. And these are individuals who often will have severe blood sugar lows from their diabetes or many kind of severe metabolic complications from their diabetes, who would be eligible for pancreas transplant alone if they do not have any sort of, if they don't have kidney failure and do not need a kidney transplant. So again, a reminder that these are typically options for patients with type 1 diabetes and a very select group of patients with type 2 who typically will receive a simultaneous pancreas kidney transplant. But again, just to touch on some of the options, the vast majority of individuals with diabetes who have type 2 diabetes will receive a kidney transplant alone. Next slide. So just to wrap up, this is a brief talk just to try to give you some of the high points. I hope I've been able to show you that diabetes is highly prevalent. Type 2 diabetes is by far the most common, but early intervention and prevention is important. That really starts with early diagnosis. That's really at the stage where a lot of prevention is possible and has a great degree of impact. The goals of the treatment once diabetic kidney disease is diagnosed is really to stop or slow the progression of kidney decline, kidney function decline. And there's lots of, especially new drugs that have been developed recently to help with that. Despite kind of our strategies, some people do progress to kidney failure, and kidney transplantation is the preferred treatment option for those patients, and ideally a living donor kidney transplant for the reasons that I've discussed. And in particular, I hope I've been able to introduce the concept of pancreas transplant for as a very important option for a subgroup of patients with diabetes. So I'll just stop there and I'll turn it over back to Paula for the next portion of the talk. Thank you.
Thank you very much, Dr. Singh. A reminder to our audience that we will be addressing your questions at the end of this webinar. So please feel free to submit questions via slido.com, and the code is kidney. I'd now like to invite Andrea Norgate, who has done a lot of work with the kidney, pancreas, and islet transplant team, and also has a personal story to share. And in these webinars, we always try to ensure that we give time to our patient partners to share stories. And Andrea, to some extent, is our patient partner today, in addition to her work with our team. So Andrea, I'll turn it over to you.
Oh, thank you, Paula. I'll go to the next slide. I've been working with people with diabetes for a very long time now. It seems like I'm at my 31st year here. Just historically with pancreas transplant, everyone's sort of always wondering, like, how come we have pancreas transplant, and why is it that I've never heard of this? And the first one was in 1966. I think it lasted about 10 minutes or so. And until we started getting some better drugs for transplantation, like in all of the transplant world, it wasn't until the drugs got a little bit better that we were able to actually have a viable transplant. And in the 1990s is when it really took off, and especially here, we started it here in UHN at around 1993. 93, 94, actually the end of 93 to 94. And it was with the advent of better immunosuppressant agents that we were actually able to sort of improve the longevity of pancreas transplant as a treatment for type 1 diabetes. UHN does about 40 to 50 transplants per year. And the reason that it's not like 100 is because that the pancreas donor, it seems to be the diva organ in the entire body. And the pancreas donor needs to be young, younger than sort of liver transplant donor can be. You know, there is no age limit for the liver, but the ideally the pancreas donor needs to be under the age of 40. And so that's why our program can only do about 40 or 50 a year. Next slide. And there's all kinds of questions. Why does diabetes actually cause so many complications in the body? It seems like there's not a single system in the body that isn't affected by it. And so if you think of it, it's just sort of like, this is your cell. And if glucose isn't on the inside of your cell, right, which insulin gets it on the inside, it sort of docks on my nails, the cell opens up, the insulin or the sugar goes inside, and then it closes up where it's nice and protected. And your body will use that glucose for energy. But when it's not inside the cell, it's on the outside of the cell. And it's when it's on the outside of the cell in increased numbers is when you can get all the damage. And if you think about it as sort of like a little shard of glass almost, and so that little tiny shard of glass is going through your entire vascular system. And so really diabetes is a disease of your vasculature, sort of like everything with a blood supply eventually will get wrecked in some way. So like the tinier the vessel in the area, the more that little shard of glass is going to sort of do damage. And it doesn't do damage tomorrow, right? It does damage over time, but decades go by pretty quickly, depending on how many you have under you. And so like, you know, perhaps the time between 10 and 20 seems like a very slow time, but I can tell you the time between 40 and 50 is pretty quick. So again, the leading cause of blindness, because the vessels in the eye are very tiny, and especially the nephron, the kidney, the vessels in the kidney are very tiny, and sort of the bombardment of the glucose in the wrong spot in a high, like not protected inside the cell, but on the outside of the cell, it just sort of bombards that vasculature and eventually just wrecks it. And that is the problem with diabetes, the complication. Insulin will keep you alive, but it's very difficult to control your sugar at all times because we're all human, and it makes it harder and harder. And so a lot of people beat themselves up a little bit over the control of glucose, whereas it's very difficult to take on the responsibility of an organ in your body. Next slide. And so the purpose of pancreas and islet cell transplant is, let's take you out of the equation, shall we? So you make your new pancreas will make insulin for you. It'll normalize your glucose without you having to sort of think about it constantly 24 hours a day. And in such, it can't reverse any of the complications of diabetes, but it can sort of maybe halt them or prevent future complications of diabetes. And with that, like taking you out of the equation of having to think about your glucose and what you're eating and how much you're exercising and injections and testing your sugar, it does improve your quality of life, and it extends, and ergo it extends your survival without having increased complications. Next slide. So at the Toronto General Hospital, or UHN, however we're saying it. I'm at Toronto General right now. We have 5 main programs. So it's kidney and pancreas together from a deceased donor, pancreas after kidney. So if you have a living donor, kidney transplant, and then you can have a pancreas afterwards. That is 2 operations. But, again, like Dr. Singh was saying, the safest thing for every person with diabetes to do is to get off dialysis. And so the quicker you can do that, so if you have a living donor and you can get that done quickly, then we can put in a pancreas afterwards and look after that glucose control for you after that. And then there's pancreas transplant alone for those people whose if your glucose goes low, sometimes you cannot feel your lows anymore. You don't have any warning signs. And if that's the case, then what happens is that becomes a very life-threatening condition. It's called hypoglycemic unawareness. And it is life-threatening because sometimes our body gives us these sort of like signals that our sugar's going low. We get very sweaty, shaky, feel weird, feel bad. And so what ends up happening is that then we can test our sugar, and if it's low, then we can sort of give ourselves a little bit more carbohydrate or glucose, however you want to describe it. And so people who don't feel it anymore are eligible to get a pancreas transplant alone. There's a lot of different criteria to qualifying for that transplant, but we do it. And then we have an islet lab too. So whole pancreas is an entire organ that we actually transplant, and we do offer islet transplant alone, whereas like currently the islet cells that make insulin are contained within the pancreas in the body. And what we do for a deceased donor pancreas, we can dissolve that pancreas down, isolate the islet cells, and what we do is we can infuse them through the portal vein and change the organ vessel for islet cells from the pancreas to the liver, and we give it to the recipient's liver. Islet cell transplant after islet cell transplant doesn't work as well or as effectively as a whole pancreas transplant. So we really defer over to the pancreas transplant as opposed to offering islet cell transplant first. The survival rates of pancreas transplant or being insulin independent after pancreas transplant are much greater than they are after islet cell transplantation. But if you cannot have a pancreas transplant for various sort of surgical reasons, then we do like to offer people a different method of transplantation with islet after kidney and islet transplant alone. Next slide. And so the benefits are good, like operative mortality, I guess so surgical risk is less than 1%. There's excellent patient and graft survival. 90% of people after 1 year post pancreas transplant will have a working pancreas and will be insulin independent. And it stabilizes your complications, and your quality of life is certainly improved, and it improves long-term survival indeed for pancreas transplantation. Next. And I show this slide just because, so this is sort of my story. So these are my kids. It's Joseph and Georgia, and that was when I put them on a bus when they were that little. So cute. And anyway, that's them much later on. That's about 3 or 5 years ago. About when Joseph was about 13 years old, he became very thirsty, and he became very sort of, he sort of grew about seemingly, I think he grew like 4 inches in a 6-month period. And so I always thought he was pretty skinny. They're pretty skinny kids to begin with, but he was losing weight and he was pretty tired all the time. And I thought, it's not good. And I had been doing this job for some time too. So anyway, we went to the emergency room because that's where I also work. And sure enough, his glucose was quite elevated. And on that day in November, he was diagnosed with type 1 diabetes. Now it's an autoimmune disease, and it's one of those sort of random things that happens to families. And of course, there's no history of diabetes in my family, and there's no history in his father's family. And so, and it's just sort of a random thing that sometimes happens. Sometimes people call it bad luck. I fully agree with that. Anyway, it happened to my Jojo, and from that day forward, I sort of view that day as one of the worst of my lives. I know there are terrible days in people's lives, but for me, that was like terrible because I work with people who have end-stage complications of this disease that my son was just diagnosed with. And as any parent knows, you would do anything to trade places with him or just take it away or make his life a little easier. But of course, we don't have that choice ever. And so what we do is we try and make the best of it. And, I try and help Joey with the best ways of managing one's glucose. But again, everything's sort of up to the individual because he's in charge of what he puts in his mouth and how much insulin he takes and how much he checks his sugar, etc. So I thought to myself, the one thing that I do know about is transplantation. And with transplantation, what I do know is that what we can do is I can give my kidney. And it's strange because normally you'd think, well, what if your child needs a kidney transplant? And I'm like, well, if my child needs a kidney transplant, I will either be dead or 90. And if I'm 90, no one wants my kidney. And I couldn't possibly bear the fact of being buried with two perfectly working kidneys. So what I did is I registered to be an anonymous donor, and I was anonymous, I guess, until now. And I gave my kidney. I'm a blood group O. And so what I could do is I started a chain. And the chain is for when people who have a bunch of living donors, but nobody matches anyone, the person with the blood group O usually can start a chain off. And then I went to Ottawa and I donated my kidney there. And that person's donor went to Toronto and that person's donor went to Calgary. I'm not sure how the chain worked after that, but it did start off a chain. And the reason I did it is so that my daughter, Georgia, could see that if Joseph ever needs a kidney, then she could donate, and she could see that it actually isn't a crazy task, and it's something that people can do quite easily. And I also did it in honor of all of my patients in the kidney pancreas program, because they've all been through that. They've all been through kidney disease and what it means and what dialysis is like and what diabetes is like. And I know every single one of my patients would donate their kidney in a heartbeat. And so I did it to honor them and to honor their experience. And from that perspective, it seemed to work out well, because Georgia saw I donated my kidney. I came back home. I sort of slept for a month. I turned into a cat, really. And then I went back to work. And I don't have any sort of complications. I'm a very healthy individual, at least I like to think. And that was a number of years ago now. And right now, Joseph is studying to be an arborist, and my daughter is in school, and they're both very much involved in the transplant world and in the world of diabetes, not by choice, but I think everyone's perspective is a little bit lighter now. And that's it.
Thank you. Thank you very much, Andrea, for sharing your expertise and your story. I'd like to remind our audience that we will be able to take your questions at slido.com, and the event code is kidney. So we've received a number of questions, and we'll be showing some of those on screen very shortly. And while we're waiting for those to come up, maybe Dr. Singh, you talked about graft longevity, and for some of our patients, they will need to get a retransplant. Could you talk a little bit about the options for those who may require a transplant again, and how frequently that happens?
Yeah, thanks, Paula. That's a great question. So, right now, although we've had great successes in transplantation, one of the big challenges that we still have is trying to keep that transplant working as long as possible. So a lot of transplants although they can last a very long time, they all eventually will fail. Our goal is to keep those transplant working as long as possible. And our ultimate goal as a transplant community is, I think, to try to get one transplant for life. But for individuals where the transplant does fail, often another kidney transplant would be required. In the ideal scenario, if one knows ahead of time, and typically this is known ahead of time, that a kidney is failing, it's a good opportunity to try to identify a potential living kidney donor who can then be eligible to donate for that second transplant. Of course, if that's not possible, there's always the possibility of, again, being placed on the deceased donor waiting list for a kidney transplant. The issue, of course, with any transplant, first or second, with the deceased donor waiting list, is the waiting time. As you may have heard, there's much more demand for kidney transplants than there is supply of organs, and that's why living donation is so important, to try to kind of really decrease the waiting time. Having more living donors that come forward really allow us to decrease the waiting time for everybody on the waiting list. But another option for transplantation is to get a transplant from a deceased donor as well. So those are the options. Retransplantation is possible, and it's certainly becoming more and more common as we see more and more people living longer with organ transplants.
Thank you very much. And we have the questions submitted on screen now. And I guess this first question is relates to the link between diabetes and neuropathy. That is very common and very painful. And I'm wondering, Dr. Singh, if you can address that question. What is the link and how do you manage neuropathy?
Yeah, so Andrea described so nicely, kind of with her diagrams with her hands, such a really nice way of explaining what happens with diabetes. And that high blood glucose, as she described as shards of glass, is really effectively what happens to the nerves in the body. The nerve fibers in the body can kind of get destroyed and damaged. And as a result, not only can nerves get damaged and it can cause pain, but it also can cause lack of sensation and increase the risk for potential foot ulcers or infections and deformities of the foot, sometimes even resulting in amputation because of decreased blood flow, as Andrea so nicely described in patients with diabetes. So the link there is that the high blood sugar, as Andrea described, damages really everything, including the nerves and the blood vessels that are going to every organ. And the prevention really here is to try to really get ahead of these complications early on, and at the time of diagnosis, really before these complications have kind of been established, is a critical time to try to mitigate or minimize the risks. And that's not just for neuropathy; it's for all kind of complications that have been discussed, and that's where really intensive glucose control comes in as well.
Thank you. Many of the questions that we've received are medical, and I'm wondering if you might be able to address the two questions that are on screen, and then potentially we'll ask for additional comments as well from Andrea.
Sure. So I'll just tackle, so I mentioned that one of the risk factors is polycystic ovarian syndrome. Polycystic ovarian syndrome is associated with a state of insulin resistance. So not necessarily that patients will get diabetes absolutely if they have polycystic ovarian syndrome, but they are more at risk of having that kind of situation of insulin resistance, meaning that they produce insulin, but really don't respond to it exactly in the way that they should. So that's really kind of, it's in a way a hormonal issue, and that's kind of why we see that relationship. Diabetes, in terms of a diagnosis of diabetes and the question of whether diabetes can be reversed, I think it's important to be clear with respect to that question if we're talking about type 1 or type 2 diabetes. I think that's an important distinction. As Andrea discussed, type 1 diabetes is an autoimmune disease, so kind of the body is attacking the islet cell in the pancreas, so that really is a process that cannot be undone. So that cannot be reversed, but as indicated, can be treated, and with the goal of course to try to mitigate the complications or minimize or stop the complications. Type 2 diabetes, in certain individuals where there are a lot of potential modifiable factors, like for example obesity or being overweight, a lot of times insulin resistance can be dramatically increased or improved with weight loss if there is weight to lose. Diet and exercise often can play an important role, but not all individuals who implement all of those kind of strategies are able to completely reverse their diabetes. They certainly can improve it, but it's certainly not a failure if one does everything right. Sometimes diabetes cannot be completely reversed, and that's because we know there's a lot of other factors in diabetes at play, including genetic predisposition. So we can control a lot of things, but we also can't control a lot of times our genetic makeup. So it's important to recognize that in some individuals, lifestyle changes can reverse blood sugar elevations, particularly in the pre-diabetic phase. But in a lot of individuals, even though lifestyle changes are implemented, maintained very successfully, often medication will still be required. So it really is dependent on the individual as well.
Thank you, Dr. Singh. Andrea, when patients are referred to your program, do you see a lot of fear? Are many of them thinking that perhaps their condition can be, reversed, that it can be controlled, that it will resolve by itself?
With respect to diabetes? Yeah, unfortunately, diabetes, like once something gets sort of once nerve damage happens, it doesn't grow back. And a lot of these complications, we can just halt them with a pancreas transplant or with glycemic control. We can halt them from getting any worse. I can certainly answer this question about your cousin referred to UHM for pancreas after kidney transplant. So the having a kidney pancreas transplant done at the same time is great. It's great, and it would be even better if there was a bunch of deceased donors that we had there was no waiting list. With a blood group O, there certainly is a waiting list. It's about 4 years for a kidney pancreas transplant. And so the best thing for a patient to do is to get off dialysis. And so although it is 2 surgeries to have a living donor kidney and a pancreas afterwards, it's still better for the patient to get off dialysis if that opportunity is available to them, rather than waiting for a deceased donor kidney pancreas together. It's 2 surgeries, yes, 2 scars, but the scars are super cool looking, and you can boast about it, I guess.
Thank you very much. The next 2 questions really are related, and maybe we can go back to Dr. Singh. When should dialysis patients consider transplant? And what are the long-term outcomes of transplant versus dialysis for patients with diabetes?
Yeah, great question. So I would say, the question about when should dialysis patients consider transplant, ideally people are considering transplantation before they even get on dialysis. The ideal scenario is what we call preemptive transplant. So when somebody is aware that their native kidneys or the kidneys that they're born with are failing because of diabetes, that is the ideal time to really start considering living a donor kidney transplantation. Because of the waiting list, it's very difficult to achieve a preemptive deceased donor kidney transplant, meaning a deceased donor transplant before dialysis required, but it certainly is possible with a living donor. That's one of the major advantages. If somebody already is on dialysis, then transplantation should be considered as soon as possible. Now, keep in mind, not every dialysis patient is eligible for a transplant. So there has to be, of course, a referral to a transplant center and assessment by that transplant center about eligibility. That takes some time to complete all of the testing required to determine if eligibility is eligible. But that's something that should be done ideally before dialysis is initiated, if a living donor is possible. And when dialysis patients when patients are on dialysis, they should be considered for transplant as soon as possible. Now, keep in mind, depending on your blood group and how long you've been on dialysis, the wait for transplantation may be long. So you may not necessarily be assessed and go through all of the testing right away for a transplant, especially if your wait time is long, because you would have to repeat that closer to the top of the waiting list. But certainly having guidance by the transplant center of when a good time to start that evaluation process is important. So that's the first one. And then the long-term outcomes of transplant versus dialysis for diabetic patients. So again, that graph that I showed you in my presentation that showed that long-term survival is better for patients who receive a kidney transplant compared to chronic dialysis alone applies for pretty much every subgroup of patients, but in particular, patients with diabetes. We know that time on dialysis, people can accrue the complications of dialysis. And so the benefits do apply to patients with diabetes as well as to those without. But in particular, diabetes, patients with diabetes certainly benefit from the transplantation. So the long-term outcomes are certainly favorable in all subgroups, including the diabetics.
Thank you, Dr. Singh. This next question is around preemptive living donor surgery, and I know that there's a lot of confusion about what happens if you are pursuing preemptive transplant. Do you still get to be on the transplant waiting list? What if you don't actually find a living donor? And some who are on the list are concerned or have questions about how they know where they are on the list, etc. So I'm wondering if you might be able to explain the process a little bit. What is the process to get on the transplant wait list in Ontario?
Yeah, Great question. So the first step in the process is on the recipient side of things. So we have a transplant recipient who is wanting to be evaluated for consideration for transplantation. The first step is to determine that that individual is eligible for a kidney transplant. Nobody's placed on the wait list until the complete evaluation at a transplant center is done and the individual has been deemed a candidate for transplantation. Once candidacy has been confirmed, typically then one is activated on the deceased donor waiting list. Now, depending on how long somebody has been on dialysis, that really tends to dictate how long you wait for a transplant. The waiting time really, the points really are accrued based on how long you are on dialysis. Now, so as a result of the long waiting lists for pretty much all blood groups, but longer for some versus the others, it's very difficult to get a preemptive deceased donor kidney transplant because the waiting lists are so long. It would be virtually, statistically almost impossible to get to the top of the list if you haven't started dialysis yet, because there's just not enough points to get to the top of the list. So the way to then get a preemptive transplant is to consider a living donor. Now, in order for a living donor kidney transplant to occur, the donor then has to be evaluated and cleared. So you need a cleared transplant recipient and a cleared donor in order for a living donor kidney transplant to occur preemptively. So while a donor is if you do have a living donor, that person can refer themselves to the program, but you can remain on the waiting list until your donor has been determined to be suitable to donate, because not all donors are approved for donation. So that is certainly a possibility. But once you've been identified as potentially having a living donor, we would then remove you from the deceased donor transplant in order to go forward with your living donor transplant.
Thank you very much, Dr. Singh. And we've reached the end of our time. And I'd like to take this opportunity to thank Dr. Sunita Singh and Andrea Norgate for joining us today, and to invite all of you to register for our upcoming webinars. Our next one will be on creating a culture of donation and transplantation on April 22nd. And there will be also a follow-up webinar to answer your questions about the COVID-19 vaccine. A reminder that April is Donor Month, and we encourage you to register and to discuss your wishes with your family. So once again, thank you very much for joining us. Thank you to our speakers today, and we look forward to seeing you next time.